Good morning, everyone. Finance Committee will come to order. Any citizens wishing to address the committee this morning? None signed in. All right, we'll move on to item 3, approval of the minutes from the March 22 meeting. I'll entertain a motion.
Move approval of the minutes for March 22nd.
A motion by Mr. Bose, second by Mr. Petty. All in favor, please say aye.
Aye.
Opposed, motion passes. Thank you. Item 4, CFO report. Clark. Good morning.
That's a good sign. But when you come to the mic, you know, down to the bottom line.
That's
No more comments from the peanut gallery. The one thing I wanted to remind you guys about is that May 10th, we will be spending a significant amount of time talking about the upcoming budget. We are going to be, I'm presenting through March, which wraps up the first half of our fiscal year. So we will begin starting to look at volumes, working with directors, managers, medical directors, vice presidents. And so this really kind of starts our budget season when we wrap up March. Sure. Okay, I'm going to roll on into the monthly report. So for March, our admissions were right on track with the budget, as you can see. And the outlier on this page is our length of stay, which is going to be on your bottom right. Our length of stay was really high this month, and just as a reminder, this is calculated only for the patients who have been discharged. And it just so happened that we had 3 very long-term patients that were discharged this month that's skewed the March result. So it's really attributable to 3 longer-term patients that we discharged this month. For our emergency, primary care, and specialty clinic visits, those were all right on budget, within 1% to 2% of where we had planned. And on urgent care, that was actually down by about 5%, but you can see they were holding their level steady from last month. We had a few less observation cases. That was down by about 10%. Again, we were pretty high on the inpatient status, so the observation cases are still in beds within our hospital walls overnight, but they're just really being evaluated at that point. So we had a lot more patient days. We had a little bit less in observation. Our invasive lab saw one of the higher months that it has seen. It's the highest month in March. As that program continues to develop, we saw 769 cases go through there this month. I did want to spend a little bit more time on surgeries. There was some discussion that occurred last month because we have had this perpetual trend now where surgeries are down anywhere 10 to 12%. And after we look at it, there's 2 main service lines that have really changed their protocol and the way that they're doing things. And you know, instead of pain management was one of those. So for example, we used to do a lot of local anesthetic that would occur in an OR. Last year, at the very end of last year, we were able to finish out a procedure room at the clinic office, and a lot of those procedures are being done there. and not tying up an OR. So the patients are still getting this service. It's just in a different, probably much more convenient location for them. Urology was another service line that had shown a decrease from the prior year. And a lot of that has to do, again, with a change in protocol and the way that those patients are receiving their treatment as well. It's counted more as a procedure because it is not in the OR. Also, we did have, if you recall, the new urology group came on at the very end of last year. So we didn't have a lot of experience with them, and we didn't know exactly what to predict for that group.
So where are you measuring that change then?
The outpatient procedures show up as a procedure within the clinic. So if you looked at our, there are hundreds of outpatient statistics that you don't see, and those are captured there, just not as a surgical visit. So I think, as we start to look at volumes for the budget 19, those are going to be taken into account, and we'll bring those budgeted volumes down to match their current state. I will say that most of the pain management cases were taking place at Jessica in our Arlington outpatient surgery, and so it was not necessarily a downtown procedure either. So
I guess I'm having a little problem understanding that big of a drop based on one procedure room. You said they started doing procedures in the outpatient?
they did at the clinic location.
At the clinic
yes.
location. Well, that must be a very large volume. Well,
Annualized, it is probably a case or two a day, perhaps. It was, if I annualized it, it was around 525 a year.
okay.
From, if you looked through our gap through March,
Okay.
and then the next 6 months.
Are all of the surgeons, physicians filled? Because it seems as though when we were changing out the surgery team, that the numbers started dropping. So is that filled now? Because I can't see that our patient volume is not going down, and I can't see that we wouldn't have that many patients still needing surgery. So I just offer.
To my knowledge, even though we are still recruiting for a couple of positions, those positions are locum or temporarily filled at this point.
Oh, okay. All right.
I can give you a little bit. The lady that's providing the peripheral vascular surgery is only here about 10 days a month, and then it's locums, but the fellow that's coming in from Arizona will be here full-time. So she will probably continue as sort of a
All right.
part-time.
Yeah. I know you probably can't answer, but are we having a waiting list for surgeries now? Has there been an
I
increase
don't
in the
know
number
the
of
answer
patients?
to that question.
That was my question from his. Oh, it did, it got squeezed.
Hi, Wanda, thank you.
Just to answer a couple of your questions, the general surgery that we changed at, we made the big changes, their volumes actually are up slightly. So we haven't seen a change there.
Okay.
Some of the changes that we have seen in the main OR particular,
We can hear you.
Get closer to the mic. There you go.
Oh,
It's
oh,
screwed
it's-
over. Yeah, it's
I
taped.
thought I'll slide it down, it's attached. We've seen a slight drop in orthopedics. We think that's probably due to the trauma.
Orthopedics, okay.
So they're down slightly, but trauma's down about 12%. So orthopedics is a big part of the trauma cases. We've talked about urology. ENT was down slightly, but oral maxillofacial has picked up the majority of those cases. So if you look at theirs, that kind of evens out there.
Right.
So that's pretty much where we've had and then the vascular that we've talked about, and that's pretty much accounts for all of our changes.
So Wanda, then have the wait times changed? Have the backlog changed relative to people being able to get into surgery?
Well, the difference that we have, like with urology, it really didn't change our day-to-day scheduling much, because when Dr. Leovano was here, he worked late into the night. He would come late and work, which was kind of the off hour, so it didn't change our actual times during the day so much. And we have so many add-on cases during the day that we just fill those gaps, every day. So.
Okay, good. Thank you.
You're welcome.
Any other questions on surgery before Wanda returns to her seat? All right.
Thank you, Wanda.
Thanks, Wanda.
It's your last chance.
Returns.
There we go. On our psychiatric service line, you can see that our patient days were up by about 6.5% for March, and the trend on the outpatient side is continuing slightly down. Our clinic visits, again, were budgeted at a too high of a rate, so they have continued to be higher than prior year. Our psych emergency visits and our partial hospitalization days were under 8 and 10%. So I've added a new graph again because of the discussions that we had last month. You'll see that we have split on the top half a day's cash on hand that's available for operations. This would exclude the $117 million that we have in the future fund. And then the total days cash on hand, which includes all of our funds, in the way that a rating agency or some other external entity would look at the way that you calculate days cash on hand. So if you look at just the available for operations, we're at about 252 compared to the right graph that includes all of the cash, which would put us at about 301. And you can see we're starting to naturally decline after our big cash receipts in January and February from the ad valorem receipts, our property taxes. Our net days receivable is at 50, so it's holding pretty steady. And our FTEs per adjusted patient day are favorable by about 3.6%. Our payer mix, this is a year-to-date slide. Again, doesn't change a whole lot on a monthly basis. And look at the colors on the JPS connection enrollment. I gathered the data back, and the yellow gold part, bottom, Robert, is the connection. Those are our traditional connection patients that do not have access to any other insurance product in Tarrant County. The little blue bar at the top is showing you where our connection supplemental patients fit into the overall mix. The totals are the same that you have always seen in the graph. We've just broken out for you now. So you can see that from December to January, we did have quite a bit of change in that connection supplemental group. But we are at 37,399 enrollees. That's about a 700 member pickup, or about 2% from last month.
So, just briefly, distinguish connection from connection supplemental in terms
Sure.
of distinguishing those two groups?
Okay, so, a lot of times we only talk about this during the budget presentation, so it's a good reminder. The connection program is here administered at JPS. Michelle has come and talked to you about our enrollment efforts and kind of 3 criteria that you have to be in for the connection program. You have to be a U.S. citizen, you have to live in Tarrant County, and you also have to qualify under a federal poverty guideline, and that works out to about 138% of that federal poverty guideline. So pretty much not eligible for any other product. The Connection Supplemental are insured patients that are medically indigent and can afford these really large copays and deductibles that are occurring. And they also have to qualify for a certain federal poverty guideline score. So this program is actually administered by our foundation. Our eligibility department takes over and determines whether they fit into that criteria. And the other restriction is that those folks must receive their care at JPS or one of our facilities. And the Connection program is not unique. Almost every large public system has a similar program.
Even states have those to help supplement your
Okay.
deductibles. Yeah.
But there's no difference in the level of care when it comes to eligibility for a supplemental patient versus a regular connection patient.
Ask that again.
There's no difference in the available services that are covered
Correct.
for a supplemental patient than there would be a basic connection patient.
That's correct, but the one requirement is those insured patients that qualify for supplemental connection do have to receive all their care here at JPS.
Okay. So
They can't go to another facility in Fort Worth and receive that assistance. They have to remain here.
And are they the same in terms of the federal poverty level guidelines?
They are not.
Okay.
These folks, again, a lot of them qualify for ACA coverage, and they're above that 138. And I can't remember exactly the cutoff. There's not a percent that it's yes or a no, but it might be like closer to 165 instead of the 138, just because by definition, if they did not qualify under the ACA, they would be in the traditional program.
So, taking a leap and just asking a question, in terms of financial impact on the system, do we do better when we're serving a connection supplemental patient than we do just a connection patient by virtue of being able to file on the primary insurance and then only having to pay for the delta?
Yes, because the Connection Supplemental do have an insurance product. Now, again, a lot of these products have a really high deductible because that's what makes them so affordable. And we are at risk for that first level of deductible and may not be receiving an insurance payment for those patients. But with the connection population, there is no other funding source and there is no insurer. So the Connection Supplemental is just an insured population that really has the ability, they're above that 138 federal poverty guideline, and they have a product. It's just not a very rich plan, which is what makes it affordable for them.
We measure, though, in terms of data, all of it goes into the 22% connection in the payer mix slide, right?
It does.
We don't
All of
distinguish
these
between
are,
the two.
well, I take that back. I believe that it would only be the gold bar because let's say that they had a Blue Cross product, high deductible, really a catastrophic plan. They would be classified as a Blue Cross patient
They're commercial.
because they're commercial. So The blue portion of that bar is going to be most likely in the commercial side, or in the Medicare side, if they're qualify still for Medicare help.
But really, in terms of net impact, that exposure that you articulated earlier is really should be reflected in the connection payer mix.
Yes.
Because in essence, it's not a reimbursed cost at the district.
Correct,
Yeah,
yes. I mean, you could look at it either way, but when you're pulling data, the primary payer is going to be listed as Blue Cross, and
Right.
secondary would be Connection Supplemental.
Okay.
And so we pull that pie chart based on your primary payer. There are a lot of patients who have access to more than one insurance product for one reason or another, but there's always a primary identified by the plan, and then the secondary we could file on behalf of that patient after the primary pays.
Okay.
So that's how it would be set up, and that's how the data comes out of the system.
Sharon, I got to follow up to Trent's question because he's got me thinking. I agree. What I hear is whether you're Connection or Connections Supplemental, once you're qualified, you're getting the same quality of service and services, except for if you're supplemental, you've got to use the JPS related facility. So
You do as a Connection patient as well.
yeah, true.
Yeah.
But I'm talking about from a standpoint of dollars and cents. I'm still concerned about the exposure and where it shows up in the pie, because if it showed as commercial, be it we paid
Yeah.
because the deductible is so high,
Yeah.
and or there, we as an institution paid for that shortfall, I hear it's not going over in the Connection payer
It would
mix.
not, by the way, I mean, we have hundreds and thousands of patients. We would be able to run a separate report that would identify the Connection Supplemental patients, but when I run the big pie chart, it is based on your
Yeah.
primary payer.
Gotcha.
So it doesn't mean that once we get our cost accounting system up and running, that we won't be able to pull those patients that are impacted in that blue bar.
Yeah.
But
Because-
they do have a payer.
I got you. And again, I go back to what you said, Trent, I agree in that there may be a very large sum of services we're providing that should be allocated maybe to that payer mix being Connection.
Not only allocated to it, but the question comes to mind, if programs like the ADA are attracting people only because it is a catastrophic insurance product
Right.
and that deductible is so high, then we're still doing the same thing we've always done, except now we're taking on the ADA risk
Yeah.
patients as well. And I guess my question then becomes, does it make sense to establish something within, and this is pure pontification. Does it make sense to look at establishing some threshold of out-of-pocket that is lower than what the catastrophic protection under ADA would do, just to be able to recover some of our risk relative to that delta that occurs when that commercial patient shows up here because they can't afford their deductible?
Either way, the commercial patient will show up here.
Yeah.
They have been showing up here, they will show up here.
Okay.
This is just an effort to identify those patients that are medically indigent, and it's more on the back end for the billing process.
And the challenge for us, Trent, and why 2 years ago we took the action is because when you can't afford that deductible and you can't afford that, you drop out of that system, and then it's really hard to get you into any of our systems because you qualify for a federal program. So then we pretty much mandate, or the federal government mandates, you're gonna come to our emergency room.
Yeah.
So we have virtually no hope of getting them into a primary care system
Right.
at all.
Yeah.
Because
It's a
every
bad
time they
cycle.
come back to our system, it's there's a federal program for you, so
Bad
we can't
cycle.
put you in. So to Sharon's point, we're going to get them either which way. We just have a much better opportunity of putting them in our system and keeping them in a continuum of care this way than if they can't pay their deductible, which they will automatically drop out. And that's what we saw initially with the ACA, is that people enroll because they're afraid they're going to be in violation of the law, or somebody's going to come, somebody's going to knock at their door. And so they enrolled, but 60 to 90 days later, when they realized what the price was going to be, they dropped out, and then they became a medical purgatory with nothing. And we couldn't help them. So then they just showed up at numbers within our emergency
Because we
room.
went to, and this was years ago, but we went to great lengths to discuss the qualification.
Oh, yeah.
Steve, I mean,
I remember that.
we spent a lot of time
Right.
talking about qualification under the ADA umbrella and where that ultimately left JPS. And so what it's come to now is we've taken the Connection Supplemental as the ability to now correctly classify those patients. But it really hasn't changed the financial impact of the ADA on us in a positive way at all, because we're still exposed to the same risk that we'd have been exposed to earlier.
Right, but the flip to that is it hasn't had the negative impact to us because we're doing the best to keep them in our system.
And now we've got primary care physician referral, we've got, the systemic approach that says,
Yes.
okay, ultimately, this becomes part of our population health
We're
goal.
not in deeper.
Yes,
And we're able to plug those people into the system like they should have been in the first
exactly.
place.
Yeah, we're actually making that, the
Yeah.
adjustment to that
Yeah.
system to work properly for the medically
Yeah.
indigent individual that's out
It's,
there.
it's an interesting paradigm when you consider all of the different mechanisms that are supposed to provide health care for people.
Right.
And at the bottom line, at the end of the day, when it's all said and done, JPS is still the
It's still
safety
us.
net.
Yeah, because when the
It's still
ACA was
us.
coming into effect, the comment I heard more than anything else is we probably won't need the public hospital.
Right,
Yeah.
oh, yeah.
I
we
heard
all
that every day.
We all
Yeah.
heard that.
Okay, well, that didn't work.
Right.
And then when the ACA came into effect, the negative effect was you signed up, but now you're out of our system and you're in no system.
Yeah, and your analogy of medical purgatory is exactly right.
Yeah.
Well, Trent,
I'm sorry.
I don't think,
No,
I
that
just
was
don't think you're just
positive
I
pontification.
don't think
It
you're
was
just pontificating. I think that's that cycle we've been talking about. At the end of the day, JPS is sitting here, those patients are still coming. I will say, Sharon, we kind of got talking about where we put them in commercial versus they're accounted for in the financial mix, but I think it is better to see how much of our Connection Supplemental is making up the total
Oh, yeah,
piece. So
I agree.
I'm
glad we're
like,
separating.
Steve, I like the way you have
helpful.
do that. Yeah,
I
I
do.
like your colors. I know Robert may not be, but we like the
I
colors.
can see there's a difference of some type there.
Good.
Shades of gray.
And if we can solve that big question, Trent, that you're working on, man, I think all of us are, boy, it's still out there, yeah.
Okay, cool. Good discussion. So for March, kind of cutting to the chase, we actually performed very well for March, about $195,000 ahead of our $750,000 budget. We did have some new things that are going through our net patient service revenue. If you recall, we entered into the URIP program, and you approved a few managed care items last month that allowed us to begin to receive as of March 1st, additional revenues through our Medicaid managed care MCOs. So this month, that impact in the revenue was close to $2.4 million, which is one of the reasons that our net patient service revenue is up. In relation to that, I also want to point out that we do have additional IGT expense down here in the purchase service. So it's not a $2.5 million pickup, but it definitely was favorable. About half of that fell to our bottom line. And then we've also discussed in the purchase service line item the impact of TCICC and the contract offload process kind of going away and moving into this URIP program. So there's a lot of changes since our budget was approved. So a lot of what we IGT for ourselves and others are going to be accounted for differently for the next few months until we get into the new budget cycle than we had anticipated in the 18 budget process. So some variances occurred there. A few of our other operating is a little bit under. Again, that is mainly some of our vaccine programs, but there's also a corresponding underage in our medical supplies. So that has a zero bottom line impact for those programs. And we've also kind of slowed down our dish accrual a bit in anticipation that we may be receiving a few less dollars by the end of the year. We will know that before we close year end, but from an operational standpoint, I want to make sure that we have good estimates in the actual column. For salaries, not only are FTEs per APD favorable year to date, as we saw in the graph, but our paid FTEs are at 5.53 compared to a 5.77 for hours. However, we do still have some overtime, and if you remember from the very first slide, our patient days were up quite a bit. So just to staff for those patient days. I do want to point out that benefits is under budget for the month. Our health insurance, the employee health claims came in this month below budget by $150,000. So again, it's really just the timing of claims since we are self-insured. We accrue for normal claims, but several months this year, we've had some extraordinarily high claims come through in our benefits, as you can see over in the year to date. We've already talked about purchase service quite a bit. Most of that is, again, for kind of the changes between the contract offload process and the new URIP program coming on board. And then we've had some supplies, pharmacy costs are running under budget. And we have some savings in other operating expense as well, which may be timing. About half of that is utilities. So our electric and phones are running less than we had budgeted. So that's good news, and those would be permanent savings. If you look at the year to date, we're still about $1.8 million off of our budget target. Again, we talked to our leadership about watching controllable expenses. And a lot of that will be determined towards the end of the year when we get notification on some of our final federal pass-through dollars.
We'll make up the difference out of the cookie fund to make sure we.
Yeah, we may have to cut those cookies down.
It's remarkable, though. I mean, if you look at the numbers and the overall scale of what we're doing and was in 1.8, it's pretty amazing.
It is. Yeah. Okay, any questions on the medical center before I move on to a claim?
When you had that group that we took out of surgery suites and put them into essentially procedural suites that are now calculated under the outpatient group, did you have to change the coding for those in terms of the service that was provided?
Change the billable code? Yes, I'm sure. I mean, it's no longer billed as a OR, but a procedure.
Which is, in the JPS world, can be converted, but it would be less costly.
It is much less, it's much cheaper, and it's also the right care at the right place. Yeah. Okay. So I'm going to move on to a claim.
Before you get into there's a lot of discussion at the federal level about the 340B drugs. Will we, at budget time, will we be making some ranges or factors or?
The debate about 340B funding has been a persistent drumbeat since John Peter Smith was here. And
Jesus was a baby.
yes, and it's challenging because we get these alerts all the time. The feds are doing this, the feds are doing that. I think it is going to be a situation that we have to constantly monitor. We have auditors in here right now from the federal government looking at our 340B program, and that is ordinary. That is a routine kind of situation. We feel really good about things, but all of us are going to go through that. I can't answer that question, Dr. Weber, because we couldn't predict where 340B is coming. If we had listened to the beat drum 8 years ago, we would have changed our budget. It is a constant kind of situation. Now, what I would say is that, and this is to your point, the pontification comment that I would make is, if you look at the true safety net facilities, 340B is critical. If you look at the expansion of 340B over time, for those that are not safety net,
Right.
that's a different circumstance, and I'm not making comment one way or the other, but for us, it's critical. For THR, who's the other large 340B player in Tarrant County, they're critical for the patient base that we get. So I don't think we'd make adjustments to our budget, because I don't know what the federal government is going to do, or what Big Pharma is going to do, or what the debate at the Washington level is going to be about that.
Okay.
But it is a constant area for us to monitor and watch.
Good, thank you. Sorry.
No, that's fine. So build encounters continue to be about 4% under. There are some open positions, and that has been the trend pretty much all year. Year to date, we're 4.5% down. We also have, again, over on this graph, we have a favorable variance for the cost per encounter. We are about 1% under for the month, but if you look year to date, we're about 6% under our budgeted cost per encounter. So that's a very favorable variance to keep track of. And Acclaim did beat their budget again, about $177,000. We had projected them at a $950,000 loss. They came in right at $770,000. And again, most of the variances for Acclaim, as you roll down the income and expenses, are due to that shortfall in encounters compared to the budget. So, you know, the 587 is due to encounters being down. We also had the impact of spring break, even though we budgeted for procedures to go down. Talking with the Acclaim folks, they actually had more providers out than were expected. That also impacts the salary dollars. So, you know, as you lower those encounters, expenses and revenues get lowered. We also had a good pickup here in our other operating revenue. As we try to solidify new contracts, we were not sure if we should be accruing for the MHMR revenue. That contract got executed, and we were able to pick up some year-to-date dollars from the revenue. So there's kind of a nice bump this month in other operating, and then we'll go more to a monthly routine now that that contract is in. And that's really the bigger variances, unless someone has questions on the month. And other operating expenses, a lot of that is due to timing of recruitment and physician continuing medical education. I do believe that's probably timing, and that they'll start to use that up during the year. But year to date, you can see here, we're still favorable at about $431,000, coming in at about $6.5 million.
Any questions for Sharon on that?
I'm done. All right. Thank you.
Thank you very much. So I want to entertain a motion to accept.
Move for approval.
All in favor, please say aye. Aye. Opposed, motion passes. Thank you both. Thank you, Sharon, and you're still on at that.
I'm
so
here all morning, yes.
Sharon Clark. So we'll move on to item B, our first contract.
So we have a managed care contract that I'm asking for approval. This again is related to the implementation of the Europe program, and Beacon provides the behavioral health for the Cook Children's Medicaid plan. So it is separate. So we brought the Cook Children's agreement to you last month, and this is a follow-up with their psychiatric services. And this amendment actually gives us an increase in the rate.
Any questions for Sharon on this item?
Recommend approval.
Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye. Opposed, motion passes. Thank you, Sharon. Item C, Vizient.
Yes, Joe is going to join me at the table for any detailed questions, but Vizient is actually our group purchasing organization that we funnel through many of our bigger contracts. So some of the services and vendors that you're going to recognize that's included in this $109 million spend is Morris Dixon for our pharmaceuticals, all comes through. That is the largest dollars that come through here. All of our med-surg supplies that are purchased, or a large number of those coming from Owens Minor, Medline, and Cardinal, also are included. We make our laboratory purchases, dietary, office supplies with Guy Brown and Staples, and some of the capital purchases are actually pulled through this GPO for Siemens and GE. We have been with the same GPO, even though they've changed names, for about 7 or 8 years now, and we're asking for a 1-year extension to the contract.
Any questions for Sharon or for Joe?
Okay.
Okay, I entertain a motion on this item. Motion by Mr. Petty, second by Dr. Weber. All in favor, please say aye. Opposed, motion passes. Thank you.
Our second contract is sort of related to that. I mentioned Guy Brown. We purchase most of our office supplies through there, and they provide delivery and distribution for those. Our estimated spend is around $740,000 a year, and this will take us through October of 2020.
Okay. Questions for Sharon or for Joe? Motion by Mr. Bose. Second. Second by Dr. Ziegler. All in favor, please say aye. Opposed? Motion passes. Thank you. Thank you, Joe.
Thank you. Strong work, Joe. Strong work.
Thanks, Joe. Not many people come up to this table
Intimidating.
during
Yeah, no.
finance, do they?
Not
They
a
just-
whole lot.
yeah.
People come sit next to you, and then when they do sit next to you, there's not a whole lot that don't get questions, so.
I
way to go.
know, but he was
He
ready.
was ready. Way to go, Joe.
And they're moving further and further away.
Yeah, be sitting next to Warren next, right?
Poor Joe.
Item E.
Okay, the last agreement that I'm requesting approval for today is for our armed security services. We have this service that goes and picks up all of the cash collections and checks from our 40 locations across Tarrant County and takes them to Chase for us so that our employees are not put at risk. This is an incumbent, and the cost to this is $105,000 for a 5-year contract of $525,000.
Any favors, any questions for Sharon on this?
How are you able to reduce the number of pickups?
So we did a study as we were negotiating this contract about some of the school-based clinics collect very little cash. So we reduced their daily pickup to a weekly pickup.
Okay, I'll entertain a motion on this item. Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Sharon.
Thank you.
Pia, item F. Good morning.
Good morning. This morning, I would like to ask for your approval for the Talent Plus agreement. This is a $855,000 3-year agreement. The annual cost is $285,000. This is in our budget for the year. We did go to RFP for this vendor, and I do ask for your approval to approve this contract.
And these are assessments for new hires?
New hires, yes, as
Not
well.
board members though, right?
Sorry.
Not board members though?
No, not board members, no.
It would cost a
no,
lot more.
Not board members.
All right. Any questions for Pia on this? Motion by Mr. Bose, second by Dr. Weber. All in favor, please say aye.
Yeah.
All right. Thank you.
Motion passes. Thank you, Pia.
Thank you.
Item F,
Pia, that was a good job not to engage in that conversation with the chair.
notable silence on your part. Commended. Good morning, Kathleen.
Good morning, everyone. I have 3 contracts today, and the first one is for Siemens Healthcare Diagnostics. This is a 5-year contract for disposable reagents for one of the analyzers in the lab that is used for immunoassay procedures such as HIV testing. This is about $689,000 a year for a $3.4 million contract over 5 years.
Included in the budget. Any questions for Kathleen?
Is it cheaper for us to have a 5-year versus a 3-year?
Yes, we actually, when we negotiate, we look at 3, 4, and 5. We also look at the age of the analyzer and whether or not it may be replaced at a later date. So all that is taken in consideration.
Motion by Mr. Bose, second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. All right.
My
Item H.
second contract is for BioSense Webster, and this is a contract for 3 years for the electrophysiology lab. It's for their disposable ablation products, the products that they're used to actually do the procedures themselves. This is a $900,000 annually for a total of $2.7 million.
Any questions for Kathleen? Motion by Mr. Petty, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Kathleen. Item I.
My last contract is with Abbott Laboratories, and that was previously St. Jude Medical, which is why you see the name there. This is a 3-year contract also for implantable supplies in the electrophysiology lab. So this would be your defibrillators, event recorders, pacemakers, and so forth. It's just over $1 million a year for a total of just over $3 million over the 3-year period.
Okay, it's included in the budget. Any questions for Kathleen?
Sorry, which company was this?
Abbott.
Abbott.
They just purchased St. Jude.
That's right.
Yeah. Questions? Entertain a motion?
So moved.
Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed? Motion passes.
Thank
Thank you
you.
very much. Linda.
Good morning. I'm here to talk to you about 2 amendments. The first one is related to a company called N4, and you might say, what in the world is that? But that used to be what was called Lawson. N4 bought Lawson, so you might be more familiar with the Lawson name. We use Lawson for our financial applications, for our supply chain applications, and for our human resources applications. Human resources is based on the number of employees we have. So the amendment before you is specifically related to the human resource portion of the N4 contract. And we need to do a true-up on the total number of employees that are covered because all of those applications relate directly to our employee numbers. So this amendment is specifically for a true-up to make that equivalent.
True-upping is important because not being true sometimes is more
Certainly
expensive.
is.
Okay, any questions from Linda? Motion by Mr. Bose, second by, what's his name? Powell, Mr. Powell. Oh, and just a note that we have to vote also on the exception to bid on this. So we have a motion and that. All in favor, please say aye. Aye. Opposed? Motion passes.
Thank you so much.
Thank you. Next item.
I'm really excited about this item. This
Yeah.
item is a new purchase for dental care within Epic. So you all know if you take good care of your mouth, it takes good care of your whole body. We can't really afford to be not giving the best possible dental care to our patients. We have about 7 dentists and some part-time dentists that are working with our patients on their dental care, and they've been doing it on paper, believe it or not. So you can imagine every time a patient comes in again, they have to go find the patient record, look it up, and then document against that. So it's not in our electronic health record. It's not part of that record that gives us the whole picture of what's going on with that patient. So this capability is an add-on module from Epic that allows us to include the documentation of all of our dental care within that electronic medical record. Isn't that exciting?
So it's integrated and it's attached to the patient record, all right? I mean, it's,
Exactly. It's using the Epic software as opposed to paper and pen.
Right.
And having it integrated with the rest of the record.
got
Is
it.
this a new one? Is this module new to Epic?
It is fairly new. It wasn't available at the time we originally bought Epic. And we've been waiting for this budget cycle to specifically present it. Dr. Huda, I would like to let you know that Dr. Huda has been working for 6 years with Epic to create this module. So we've had tremendous input into exactly what this module looks like based on some great diligence on her part.
That is great. Okay, the motion on this, it will need to include the exception to bid, so.
Yes, because it's directly
We have
integrated
a
into
motion by
Epic.
Mr. Petty, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. Thank you, Melinda.
Thank you.
Just so you know the depth of this team, that's medical advice from your CIO.
Yeah, right. I'll learn that from Dr.
Item L, Mr. Early.
This is an
This is
appointment,
Scott's favorite part.
Scott Rule to the city of North Richland Hills, and they sent me a letter saying they want Scott back. So.
It surprised us all. I know. It's,
Yeah, I framed it. So all I need is a motion to put Scott Rule back on the.
motion by Mr. Powell, second by Dr. Weber. All in favor, please say aye. Opposed? I'd vote no, just for you, Scott, but I'm gonna go ahead and go with the yeses, so motion passes. All right, thank you.
Yes, Scott.
Any report from legal?
Yeah, for the month of March, there were 26 contracts negotiated on behalf of the district that were under 200,000 and 3 that were between 200,000 and 500, and those are on the portal for your review.
Okay. Any questions for council on those? We have nothing closed. All right. Any other business come before the Finance Committee? We are adjourned. Thank you.
There you go.
How about that?
Yeah, well, I'm telling you. Is Charlie skating or walking?
Good afternoon, everybody. It's 12 o'clock, and I will call the meeting of the Governance Committee of JPS Hospital to order. I'm sorry if you hear my teeth chattering. For some reason, we've made sure the air conditioning works early this season.
Go ahead and take them out then. I'll pay for that. I'll probably pay for that.
With all the power invested in me as chairman of the Governance Committee, I proclaim this as the Blue Ribbon Governance Committee at our last board meeting, so I hope that none of us let our peers down in this matter. Any citizens wishing to address the committee? No. Seeing none, I'll move for approval of the minutes from February 22nd.
So moved.
I have a motion by Ms. DeBose and a second by Mr. Powell. All in favor?
Aye.
Any opposed? Motion passes. Just a quick chair report. I have a hard stop at 1:30 today, so if you see me here 1 second and you see me gone, Chairman Powell has agreed to continue the meeting if we're not done with our business.
Forget it.
I'll make sure that we rearrange the meeting to get all the formal business taken care of, and then we'll move on from there.
All right.
First up is an ERM update. Ron?
All right, thank you. There we go. So for the ERM update today, I have a couple of new items, as I mentioned in previous meetings. One of the things we've been talking about over the last few meetings is emerging risks. I think a question was last time is how do we know what we assessed in our risk assessment is addressing emerging risk for JPS, emerging risk in the industry, and so I want to present some material today around that. This first slide is from a survey that a company did is for healthcare entities around ERM, and so their executives, boards, board members, and others selected certain of their top ERM risks for their healthcare institutions, and these are the top 6 that out of that particular survey. And so one of them is the changing nature of healthcare, and so that's a very, very vague term. But how that relates to what we have talked about at JPS is, when we talk about changing nature of healthcare, they're referring to the population health initiatives, the move toward value-based care. And so care coordination, patient experience, and physician engagement all are a part or a component of how they define the changing nature of healthcare, because those are key aspects that healthcare organizations need to face. And by the way, one of the other reasons I'm bringing this up is that I mentioned to you all as board members that I'd reach out to you individually. But I know sometimes, you need to have some context of what others are doing, benchmarking and that type of thing. And so hopefully this will be helpful to you. And I'll also provide you the full survey that has, I think, 15 risks that board members identified at other organizations. Cyber liability, we've talked some about this in terms of the whole cybersecurity threat at healthcare organizations, ransomware, social media, texting, electronic medical records. And as a matter of fact, at the June meeting, we plan to have David Mendenhall to present a brief board-level cybersecurity update or education, and are actually considering this, as I mentioned, as kind of our 11th area of ERM risk for the organization. The third one is recruitment, retention, and succession planning. I know JPS, as many of you know, is mainly in the HR committee, has dealt with most all of these issues, particularly succession planning. But in our list of 10 that we've dealt with, authority and accountability, which is in the people pillar, kind of addresses this in terms of loss of key employees and impact to the organization. Network integrity, capacity, and backup is all around the IT space in terms of availability, data integrity, business continuity, some of which will be discussed in the cybersecurity discussion, and some of which is, for us to discuss whether or not, this raises a level of prominence at JPS as we talk. Payer mix and reimbursement. I know we just had finance committee, and so I know Sharon has gone through that in prior finance committees, but just the whole aspect of managed care contracting and how, again, the move toward value-based care and how we get reimbursed, and in the JPS context, the various complex reimbursement models that we're under, whether it be DISH or DISRIP or IGT, 1115 waiver, and the like. Denials management, all of that falls within this category. And then lastly, cost management. And I know Sharon talked about this as well in terms of the budget process at JPS, in terms of, this is on the cost side of the equation. So, we talked about cost accounting, I know, in other committee meetings, but also just the growing costs within healthcare around compliance, technology, infrastructure, staffing, productivity, and the like. And so that rounds out the kind of their top 6. So I'll stop there. There are about 15 or so that these organizations identified as their top ones, but I wanted to at least give you a sense of it, and I'm happy to take any questions before I move on this.
Rhonda, that full report is on the board portal?
No, I got this report late, so I will post it. I will post the full report that has all 15 and an explanation of how they got on there. Yeah.
Any questions?
Okay. All right, moving on. This next piece is new content. I think I mentioned to the group before that I was putting together an ERM dashboard, and this is the first iteration of that. And I'm happy to take any feedback in terms of how we can make this better or what you would like to see. So what we tried to put here is a dashboard, and I really tried to stay away from the red, yellow, green colors because because the red, yellow, green has certain connotations to them that may not be applicable here. And so, and I know it's helpful for Robert not to get into certain color ranges. So, so what this shows is for each of the 10, there's 2 slides. This is the first one. Each of the 10 ERM areas that we've discussed over the past year, it shows the area. So the first one there in the top left is academic programs. And so there's 2 arrows. The black arrow is the baseline of when I met with the executives and others within JPS last year, and they identified, where they were at that time. That's what that black arrow represents, and the spectrum is on maturity. So this is where our journey is along the continuum of maturity, and so it's not high, medium, or low. It's like where are we going in terms of the maturity of each of these risk areas, if that makes sense. So I'll just as a review, on the far left is initial, and then you have repeatable, defined, managed, and then the far right is optimized. And just as a reminder, it's not the goal necessarily for every area to be in the optimized category. You know, these are levels of maturity. So you could still have a very well-running program, say, in the defined space, because you have hardwired procedures, processes, those kinds of things.
What's the darker arrow again, Ron?
The darker arrows are baseline. So from a year ago, this is where we thought we were, the executives over those areas. The green arrow is where we think we are today. Since where have we progressed over the last year or so? And there was some, and so what I did is I went to each of the executives, and I'll mention, and as Dr. Weber mentioned before the meeting, since there are some new leaders at JPS in some of these areas, I'm going to go to those new leaders and kind of reassess from their perspectives of where they are in some of these areas. But I did go to many of these leaders, and they believe that the green arrow represents where we are today based upon certain criteria. So the criteria, for example, is in those bullets below each of these identified the number of risks that we identified in our risk profiles that are in your board portal, the one-pagers that we discussed. So part of the criteria for the green arrow is how well have we done in mitigating the risks that we previously had identified, which was the question we had last time, and then what are some of the risk mitigation strategies, which are also in those one-page summaries, in terms of, you know, have they been implemented now? What's the efficacy of each of those programs? Have they really moved the needle in terms of our program maturity in each of these areas? And so the green arrow is based upon some current criteria. And so what I'm hoping to do is have this dashboard with the governance committee each time. And I'll say, just to set expectations, it doesn't necessarily mean because we meet every other month that the green arrow will move every single time, because these are, as Robert said, big rock areas. These are pretty large areas. But what I am hoping to do is give you in the bullets some progress report of where we are in each of these. And then if you'd like, we can take deeper dives with the executives in question on any particular one as we add to this. Does that make sense? Mm-hmm. Okay.
When I see repeatable, does that mean that you're going back and need to revalidate something? Because on several of them, one of them you got repeatable. Is it repeating the risk?
No, it's a good question. And I actually failed to mention one other element of this graphic. There's a white star in each of these crescent dashboards, and that white star represents where the executives that are over these areas believe we should be as a program, our goal for each of these. So if you look at academic programs, the leaders in that area believe that we're aspiring to be at the defined level of maturity within a 2 to 3 year period of time. That's the period of time last year that we discussed. So in that case, using that as an example, we were at initial last year. We believe we're at repeatable now. Repeatable means basically that, you know, we have gone past having initial is you really don't have established processes in place, or they're inconsistent. You have ad hoc, processes. You have people who are really good people, but what we used to call individual heroism. If it wasn't for these people, things wouldn't be as well as they were today. So repeatable means is we do have policies and procedures in place. We do have processes. They're working on getting hardwired to where they become automatic in the process. We haven't quite arrived yet, but it is at a higher level of maturity than, say, initial.
I don't anticipate that we regress on any of these categories, but on the chance that we do, how will you show that?
Yeah, that's a good question as well. Maybe I can have a red arrow, but
I don't want to make Dr. Weber upset.
If it's red, I couldn't see it. So
Right.
I'm more than happy.
Yeah. So, but no, good question. I think, and I know I discussed this with Robert and Bill and others as well, is that we wanted, as opposed to just having the one arrow, we thought it's important to have two so you can show progress. And so if it goes the other way, then that'll be part of the explanation in terms of, the arrow would go back toward the baseline, or, heaven forbid, if it goes below the baseline, that would be a part of the discussion.
Well, with 10 top risks, I mean, it's hard to work on all of them simultaneously and have them all improve simultaneously.
That's true. That's true. And as you'll notice, and I'll as you looked at the second page as well, some of them, the arrow hasn't moved quite that much. It might be, for example, I'm looking on the second page at strategic partnerships, where we have it in repeatable, and it's still in repeatable, but a higher level within repeatable. So we've made some progress, but again, these are big areas, and there's a lot of factors that go into each one, and so it's not like every 2 or 3 months that we'll get a order of magnitude change, in terms of that, because it does require a lot of effort, investment in some cases. But I'm open for feedback in terms of if this makes sense. I tried to come up with something that was fairly clean. I couldn't quite get it on one page. It would be a little bit too small, but I'm working on trying to find a way to keep all of these in front of you, but also let you know where we stand and where we progress on.
Well, we see a lot of dashboards, and this is one this Aggie can really understand, so I appreciate that.
Okay.
Any other questions regarding the dashboards?
I mean, if an Aggie can take it.
Right. Yeah.
You can get a better seal of approval.
Oh, I know, right? Yeah. Where's Neil when you need him? Right?
Maybe we could redefine repeatable. That's the one that I think is, maybe need to be
Okay.
another definition or look at.
Okay. What I could do, and I'm glad you brought that. You've seen this before, but I have a one-pager that has a definition of all 5 of these.
Right.
And maybe I include that in the portal or with this so that you can see what the criteria are for movement of that green needle.
Right, okay.
Okay.
That might help, okay.
I think that'd be beneficial.
Okay.
Just for our department chair, our chairman of the committee, today was Baylor, green and yellow. Texas Tech. I'm getting some for you out of respect.
Well, I appreciate that. I just need to make sure that we get Mr. Adams in a picture with you when that happens.
The last thing I would say on ERM is Irena Hughes, which all of you I've introduced as our policy and procedure manager, has now taken a role as our enterprise risk management manager, which means that she's still responsible for policies and procedures, but she's also going to be helping me more formally to kind of roll out this program and work with the executive owners. And so one of the things that we're going to do is to roll out the ASHRM, as I mentioned, the American Society of Healthcare Risk Management, which is from a healthcare perspective, the framework, this program, and she's actually getting, at ASHRM now, getting kind of formally trained in that methodology. So that concludes my ERM report.
May I just make one suggestion on
Yes.
your rest of your report?
Yes.
Maybe the next time, once the employees that's gone, we can take their names off of the report.
Oh, yeah. Yeah, Dr. Weber mentioned that to me as well. Yes, I will do that, and I'll update the risk
Yeah.
owners. Yes. Okay.
Ready for compliance?
Okay, so compliance program report. So starting off with a few industry headlines, as I like to do. I was just at the National Healthcare Compliance Conference that happens every year, and it's always an oxymoron when it's in Vegas that you have compliance and ethics and you have it in Vegas, but that's where they've chosen to do it. I know, right?
Yeah, I didn't know about that one in Vegas. I probably would have.
Right.
Should have signed up for that one.
Exactly. So every year at HCCA, they have the Inspector General of the OIG, Dan Levinson, to give a keynote speech about where the government is doing in terms of enforcement action, and then he has all of his attorneys that are over HIPAA and various other areas to do breakout sessions, about where the government is doing. In general, what we are hearing, and we actually heard this from our vendor that did some cybersecurity work, is that enforcement actions are actually going down. However, the fines related to enforcement actions are going up. It seems that with the change in administration, that with budget cuts and whatnot, that these fines that you see oftentimes are going towards funding the HHS budget and other kinds of things. And so that doesn't mean that that they're taking their foot off the pedal. It's just that they're really digging in when they take up a case. So in this first case, the Fresenius Medical Care of North America, this was a HIPAA violation that settled for $3.5 million. And that had allegations of 5 separate HIPAA violations. Fresenius operates 2,200 dialysis clinics and has an outpatient cardiac and vascular lab operation. And kind of over a period of time, they've had a number of breaches with respect to lack of policies and procedures, removal of hardware and IT equipment that had PHI on it that was not appropriately removed off of it when it was disposed of. And so that was considered a breach. And so they didn't just have one instance, they had several instances that ultimately led to this settlement. And again, one of the reasons why I have these up here is not just to, celebrate in the misfortunes of others, but also to talk about, how these potentially relate to JPS and the relevancy. And so when we talk about cybersecurity and technology, these are conversations I know I've had with Melinda and David around our process for making sure that if we have biomedical equipment, for example, that data is extracted appropriately from those. The second case is
Can I make a comment
yes.
just about HIPAA violations, if I may?
Mhm.
The HIPAA violations have really become almost onerous, some of them. But, for example, when the district attorney, Sharon, was here and presented her presentation to the full board, one of her slides had patients' names that were part of lawsuits. I asked Neil if that was truly a HIPAA violation to be showing that publicly, and he said it probably was. My counsel to everybody that presents here is please leave patient names off of any presentation that gets made to the group. That's my comment.
No, absolutely, absolutely, because you can inadvertently cause a breach just by doing reporting. Yeah, that's what happened to Memorial Hermann. I think we talked about that a few meetings ago, where they appropriately intercepted a person who was breaching their information. They went to their PR part of the organization, and they did a wide distribution saying, hey, this is what happened, and they had the patient's name and other information specifically in that distribution. And they got fined just because it was kind of a unforced error, so to speak, to your point.
Thank you.
No, absolutely. That's a great point. Cyber attack at Hancock Regional Hospital in Greenfield, Indiana. So that was at the beginning of this year. And actually, the OIG at the conference spoke about this specific case. And, Hancock had some ransomware that was left, had a cyber attack on their computer screens. And so they had someone to open up an email that had a piece of ransomware on it. It infected their system. Ultimately, it really shut down the EMR at Hancock to where they were literally could not, and they had to go to downtime procedures. They could not operate the hospital. And then they were offered the attacker had a Bitcoin ransom in Bitcoin. It doesn't necessarily disclose what the dollar amount of Bitcoin it was, but but they actually called the FBI into this case. The hospital leaders made a statement indicating that this was a sophisticated attack and it's not a 15-year-old kid sitting at his mother's basement. And the FBI concurred with that. And they believe it's a state-sponsored attack, potentially the Chinese or others. Because healthcare information, as we've talked about before, has very high value and content. And then it kind of goes on to talk about how healthcare industry is a prime target for cyber criminals, which we've talked about before. And so it doesn't indicate whether they paid the ransom, because sometimes organizations, depending if they don't, what their infrastructure is, choose to pay the ransom or choose not to. I know in the cyber discussions that we've had, is usually, if you can avoid, it's usually beneficial not to pay the ransom and to go back to your backups and other kinds of things. And so, this is the reason why, we're going to have David to come in next time in June to talk about the JPS cyber posture and kind of what our security is. I think you'll be, I don't want to steal David's thunder, but I think you'll be happy to hear some of the things that we have in place at JPS in this regard, because this is an ongoing thing, and no organization is exempt, whether it be private, public, or any other. And then lastly, I heard this mentioned at the Finance Committee at the last meeting on 340B. 340B, is still a lot of uncertainty as to whether the program is going to be cut, what the changing nature of the program is. The American Hospital Association has taken a position in support of the program, particularly for those vulnerable populations like the ones that we serve. And they have been, the AHA and others, and of course we're a part of AHA and others, have been lobbying Congress to support 340B. And so it's still, and this is really what this article is saying, it's still kind of up in the air in terms of where things are. Now, as Robert mentioned in finance, we do have a HRSA, and I actually have a bullet point on the next slide. We have a HRSA audit that's underway right now. So that HRSA is the governmental agency within HHS that governs that is the agency that regulates the 340B program. And so actually this morning, HRSA had its kickoff call with us and our pharmacy folks around, our clinics and what we do. And they're going to be on site here in mid-June to conduct their about a 3-day audit of our 340B program. And so, again, it's not anything related to anything we've done wrong. It's just a normal course of business audit because, as a safety net hospital, we're a very significant participant in 340B. On the compliance program update, so. On this first bullet, I know I was kind of made fun of when I called something cool, but in compliance. But this truly is, is an aspect that, sometimes you don't get to see the good work that folks are doing. But I mentioned to you several meetings ago that we implemented a new HIPAA monitoring software called Maze Analytics, and so that's already implemented and underway. I'll have more reporting in the future, but the good news, the headline is that 97% of the JPS Epic accesses were immediately matched as being appropriate, and meaning that there was appropriate means there's several criteria for appropriate because there's algorithms in the software. So anybody that was a patient here that the care team went into their record, added to the record, added a note, did any coding, did anything to amend or add to the record were deemed to be appropriate because there was a normal course of business, and so those were deemed to be appropriate. So and so those are considered to be matched. Now that doesn't necessarily mean, be clear here, that doesn't necessarily mean that we have 3% that were inappropriate. That we have 3% that we couldn't match immediately as being appropriate. So as the software gets more used to the JPS access patterns and other kinds of things, we will hopefully get that 97% up over time. But I thought that was a good initial headline that the vast majority of all Epic use is appropriate. And in most cases, when you talk about compliance and monitoring for inappropriate accesses, you're really talking about less than 1% in most cases on an industry standpoint that could potentially be inappropriate. So what the software will now allow us to do is, on a targeted basis, choose the kind of algorithm saying, okay, how many people access their own record? How many people access, say, a coworker's record when it wasn't supposed to be accessed? And so we can be very targeted. And so we have a interface from both Epic and Lawson that shows all of the Epic accesses across all the clinics, all the JPS locations. And so we are now able to holistically see what we couldn't see before. So it's a great advancement toward where we should be. I mentioned the second bullet already in terms of the HRSA audit that's underway. The third bullet, OCR mock audit. I've talked about this in the past. It's now underway. Our vendor, DHG, is going to do a look at the security rule and the privacy rule in terms of our compliance. And so they'll be on site here beginning of June. And so we've already provided them information around that. Again, this just better prepares us for if we do get audited by the government, by OCR, to be prepared for what, any weaknesses in our program.
What does THG stand for?
DHG is Dixon Hughes Goodman. It's a accounting firm, They're based out of Carolinas, and we went through an RFP process and selected them, and they have expertise in kind of doing these HIPAA mock audits.
Okay, great, thank you.
Yeah. The next bullet is conflict of interest. As many of you know, every year we have all JPS employees issued a conflict of interest statement, as well as all physicians and providers. This was as of the time of this slide, but I can tell you now that 100% of all JPS employees have complied with their conflict of interest disclosure. I confirmed that yesterday. And it's a higher percentage of providers. I want to say it's in the 90-something percent. We have less than 50 providers that are outstanding in terms of their conflict of interest disclosure, and most of those, a vast majority of those, are physicians that aren't hardly ever here at JPS. They have privileges here, so that's what made them put them on the list, but they may have had one event or one procedure that was done here a year ago, or whatever the case may be, or locums physicians or things of that nature. And so we're working with the med staff office on those physicians to say when they go to get re-privileged, that they'll need to fill out this conflict of interest statement as a part of re-privileging to be here. So, yeah, so I was really happy with that. Acclaim really did a great job in complying with their conflict of interest statements, and I applaud Acclaim for that. And then lastly, we, at the next meeting in June, will be prepared to brief on our next compliance audit, which would be in radiation oncology for IMRT, which is a specific radiation oncology treatment. And we're finalizing that report now, and so we'll be ready to present that at the next meeting.
Anybody have any questions for Ron before we move to internal audit?
I do have one question.
Yeah.
You had some information
Yes.
for the board
Yes.
on the EMR risk domains. Is that something you're going to be covering with us? Or
Yes, I'm
you're
glad.
going to be using it?
Thank you for
Where are you looking, Dorothy?
in the portal.
It's in your portal. I have a hard copy. It says EMR risk domain, part of our board education information. That was risk management of the board and leveraging the value.
Yeah.
It's one of those.
Yes. Thank you for bringing that up. I meant to reference that earlier. So what's in your portal is that article, and in that article is specifically a board article for board members about what the ASHRM ERM risk methodology and profile that we are using, what the definitions of it. It has some questions for board members that, in terms of how you can be asking us as management how we're doing with ERM. And so I thought it would be helpful from a background standpoint as we have more detailed discussions for you actually to see the framework that we're following.
Oh, okay.
Yeah.
All right. Well, I like the EMR risk domains. It kind of defines it exactly what we're doing, except it put it in like one was a hazard. That was.
Yes.
Yeah.
Yes. And so each of those risk domains, we have JPS risk divided in each of those 8 domains. And so in a future discussion, I'm going to have actually a one-page slide that has all those domains on it and our specific risk.
Okay.
Yeah.
Thank you.
Yeah, thank you for that.
Questions?
That's it for me.
Hi, Michelle. How about internal audit?
Great. We have just one slide for internal audit right before you. It's just to give you an update on our projects that you approved for FY18. The board date there is estimated for the presentations in closed session. All of those projects are currently either in progress or have yet to be started. Any questions? Okay. That's all. Concludes my internal audit. Open session update.
What you should have is a graph of arrows on
Oh.
how advanced moving these to one slide.
I'll work on that.
That arrow is doing really well to be grid. So thank you.
Okay. Thank you, sir.
Any questions?
All right. I'm going to go ahead and we're going to skip down to item 7. Take care of our executive session, get that under control, and then we will come back and end the meeting with item number 6. If everyone could indulge me on that, I would appreciate it. So at 12:33, we will adjourn to executive session.
question for you, and I